Welcome to this presentation. This is a presentation that has been long in the planning, and it's finally going to happen. And I'm so excited that Anderson Hall is available and that Dr. Van Gelder is available, that we can have this today. I'm Gini Stimpson, and I'm the co-chair with Kathy Cullen of the Low Vision Hearing Challenge Committee. And when Mary Kinney was the co-chair, she contacted Dr. Van Gelder's office. She actually called Harborview and said, who's the best speaker who can come and speak to us about what's happening with the eye, what we're learning about the eye this day, and what's happening with research. So what I want to tell you from the conversation I've had this morning, or this afternoon, is that Dr. Van Gelder said he gives this in two parts. And this is about what we're learning about the eye diseases right now. But the research part is a separate presentation. He said if we like him, we can invite him back. And I said, well, I suspect that's going to happen. So thank you for being here today, too. It's nice to see so many of you here. And Carrie, thank you for doing the filming for us. There's so many people that make these things happen that are sometimes in the background. So Dr. Van Gelder's contact is going to sit in this chair, and when she comes in, I want to be sure to introduce her because she has been very instrumental in making this happen. She also wrote this for me to say. Thank you for being here, and welcome to this afternoon's talk featuring the University of Washington's Medicine Vision Sciences and the chair of the Department of Ophthalmology, Dr. Russell Van Gelder. I have the pleasure of sharing a bit more about Dr. Van Gelder before we bring him to the podium. Dr. Van Gelder was born and raised around New York City. He attended Stanford University for his undergraduate degree, as well as his MD and PhD in neuroscience. Following his internal medicine internship at Stanford, he completed his residency in ophthalmology at Barnes-Jewish Hospital in Washington University in St. Louis, where he remained on the faculty for 10 years. In 2008, Dr. Van Gelder came to the University of Washington to take the helm as chair of the Department of Ophthalmology. He currently holds the Boyd C. Bunsey Memorial Chair and is director of both the UW Medicine Eye Institute and the Corrales Johnson Retina Center. Dr. Van Gelder is also an active clinician scientist who is deeply committed to patient care and translational research. His laboratory is at the forefront of non-visual ocular photoreception and molecular diagnostics of ocular inflammatory disease. Wow. He'll explain more what those words mean in his talk. In addition to his administrative, clinical, educational, and scientific endeavors, Dr. Van Gelder is also actively engaged with the community around vision sciences and care. Prior to the pandemic, you'd regularly see Dr. Van Gelder speaking at engagements like this. So it's a distinct honor to have him here today with us for his first community talk in several years. Yes. Please join me in welcoming Dr. Van Gelder. Who was on that, had my foot in the area of both research and implementation of the research. And I think it's such a big thing to do, isn't it? To have your foot in both those worlds and to know what's happening. Thank you.
Well, thank you so much for that very kind introduction, Ginny. First, can everyone hear me okay? Turn it up a little bit. Okay. A bit louder. Okay. Well, is this a little better?
Yeah.
Wonderful.
And we're good at calling out.
Yeah, if you can't hear, please wave your arms. And also, I have to remind myself, I do have slides, but I'm going to remind myself not to rely too much on them because I'm sure a few people in here have difficulty with the visuals, so we'll try to explain everything that's on the slides as well. Well, thank you again, Jimmy, for that wonderful introduction. Seattle is a big city that's also a very small town. And Gini was a teacher at Mercer Island High School where my kids went for years, and they're both in graduate school now. And this is a small community, and as a community, we need to really work together. And what I'm going to talk today about is how we're working at the Eye Institute and University of Washington to try to address some of the issues that we have in eye health and vision health. As Gini mentioned, I have two talks that I give on this topic. One is a very clinical talk, and that's this one, where we're going to talk about why people lose their vision and what we're doing about it. And then I have a second talk that's really directed at some of the research that we're specifically doing at University of Washington that's on the cutting edge of really vision science and things like restorative medicine for degenerative disease in the eye. So again, if this resonates, then I'm happy to come back and give that second talk at a later point. All right, so let's talk a little bit. I'm not sure that is advancing. So Katie, if we can go forward a slide.
Yep.
No?
It worked for me, but not on there. Where did Lisa go? There we go.
Okay, so I have a visual on the screen of the eye, and the I think we take our eyes for granted until they stop working, and then we realize, boy, this is a very important small little piece of the body. The eye is very much like a camera, and that's the analogy I use with my patients. Light comes in really from the stars. Most of the light that we see either is directly from our closest star, the sun, or is a result of energy the sun has lent us for a while. And the light rays, which are, I'm not sure I have a pointer on here, but the light rays, which are photons, come into the eye through the cornea, the clear part at the front of the eye, and they're focused by the cornea and the lens into an image, just as would occur in your camera. Now, at this audience, when I say the retina is like the film of the camera, you all go, okay, I get that. If I go to the middle school and say the retina is like the film, they say, what's film? And so I have to use the digital sensor analogy. But for this audience, I think we all remember film. So really, the retina converts the light energy into first chemical signals, and then secondly into electrical signals that go out the optic nerve at the back of the eye, and the optic nerve communicates to the brain and transmits that information then to the brain, which then basically decodes the information coming from the optic nerve and creates the sensation of vision. So when we have a problem with our visual system, it's either because the image isn't getting formed well, or if the image is formed well, the retina can't convert it into a signal that the brain can understand. So let's go to the next slide. Now the retina turns out to be a very critical player in this process. Many, in fact, 3 of the 4 diseases I'm going to talk about today are based in the retina. And when things go wrong in the eye, the retina is the most common place for there to be a problem. So the retina is like a layer cake. It's a very thin tissue. It's only about a millimeter or 2 thick. But it has 3 different cell layers in it. It's actually built backwards. If I asked any of you to engineer a retina, you would build it exactly the opposite way to how evolution has developed it. Light actually comes in through the wrong side of the retina. It has to penetrate through all the cell layers in order to get to the photoreceptors, which are the rods and the cones of the retina. The magic happens in the rods and cones. We have a protein called rhodopsin that has a vitamin A derivative in it, retinaldehyde. And that retinaldehyde is like a little spring trap. It starts out in a bent position with energy in it, and when a photon of light hits it, it snaps very quickly into a straight position, and that snapping action triggers an enzyme that, through sort of a mousetrap set of chemical steps, opens up an ion channel in the photoreceptors. That then tells the photoreceptors to send another chemical signal called glutamate to the middle cells on the retina, which are called the bipolar cells. They integrate signals from a bunch of photoreceptors, and then they have a signal, which is the same glutamate, that goes to the ganglion cells. And the ganglion cells are the cells that are the neurons in the retina. They have the long processes that actually go into the brain and make up the optic nerve. So the ganglion cells turn out to be a major point of disease, and particularly the disease glaucoma that we'll talk about. And the photoreceptors are the other key disease in the retina, where we have one cell type that's affected, and that's affected in macular degeneration, which we'll also talk about. So, next slide. Now, when you come to see us, the ophthalmologist, I should ask just so I get a sense with my audience of where we all are. How many of you have seen an ophthalmologist in the last year or two? I love you guys. You're keeping us in business. Thank you for your business. How many of you have had eye surgery? That's 3/4 at least. So think about that for a second. There is no other kind of doctor that I would have asked that about that 3/4 of you would have raised your hand. I'm sure some of you have seen the urologist or the gynecologist or the cardiac surgeon at some point in your life, but there's no other kind of surgeon where almost the entire room would say, yeah, I've had eye surgery. And that's because our eyes frequently fail us, especially as we get into more advanced years. And thankfully, we can fix a lot of the things that fail us through surgery, and almost all of you have had that experience. So I'm preaching to the choir a bit here. When you come to see us, as you know, we measure a few things. We measure your visual acuity, we measure your pupillary responses and look to see how accurate the pupil, how brisk the pupil responses are. That's a very good measure of the overall health of the eye. We look at how your eyes move. We check your pressure, very important for glaucoma screening to check the eye pressure. We look with a microscope called a slit lamp, and then we should do at least once a year a dilated exam where you get the drops that open up your pupil, and then we take that little headset and look in the back of the eye at the retina. And that's a complete eye exam. And really everyone over the age of 65 should be having this annually if you're not already. Next slide. So, why do people go blind? Well, there are many reasons, and our textbook that we have our residents read to learn to become ophthalmologists is 13 volumes, and it's about 3,000 pages, and that's the minimum amount of information you need to know to be an ophthalmic surgeon. So there's a lot, for a very small organ, there's a lot of diseases and a lot of things to know. But as in all things in medicine, common things are common, and there are a few diseases that are the major causes of blindness in our society. I've shown pictures of the 4 major ones up here, and these are the ones we'll talk about today. And those are cataract, macular degeneration, diabetic retinopathy, and glaucoma. And those will be the 4 diseases that we talk about. I'm not going to ask you for, because I don't want to breach privacy more than I already have, but if I did ask you how many of you have had one of those 4 diseases, I'm pretty sure it's going to be almost every hand that went up for who's had eye surgery and who sees an ophthalmologist. These are very, very common, as we'll talk about in a second. So next slide. So what I have up on the screen are the demographics of 2 of these diseases, which are cataracts and macular degeneration. And I have the curves of how prevalent these diseases are with age. And what the curves show is that basically by the time you're age 80, the odds are about 3 in 4 that you've had cataracts significant enough to need surgical intervention. It's relatively rare for us to see a patient who's over 80, who's had good access to health care, who has not had their cataracts out, because generally the lenses will be cloudy enough by that point that they'll be impeding vision. The slide also shows the breakdown in demographics between white populations and black populations, Hispanic populations. And the nice thing about eye disease is they're generally equal opportunity diseases. If you live long enough, it doesn't matter what the color of your skin is or what your sex or gender is, you're going to get cataracts. Macular degeneration too, although that tends to be a bit more of a disease of people of Northern European descent, and the rates are a little lower in people who are either black or of Hispanic descent, but they're still substantial. By the age of 85, 1 in 3 people will have signs of macular degeneration. So that's a very high number, and about 15% of 80-year-olds will have significant macular degeneration that's affecting their vision. So these are very, very common conditions. Next slide. Now, this creates a bit of a crisis for us in ophthalmology. As you are all well aware, because you all probably sat on a waiting list for quite a while to get into Horizon House and live in this wonderful facility, there's a lot of people who are living a lot longer, and that's a wonderful thing. This is the benefit of modern medicine. But when you take a demographic that says that we as a society are getting older, and a disease process that becomes more prevalent with age, we end up with essentially an epidemic of disease. And that's what we're seeing now, and that's one of the reasons it's hard to get an appointment with an ophthalmologist. It's because there are a lot of people, and a lot more people with eye problems than there were 10 years ago or 20 years ago. So, and in fact, I like this slide because it shows that the number of individuals who are 85 or over by the year 2050 is going to be about where the number of 65-year-olds were in this country in 1980. So really 85 is the new 65. So next slide. Yeah, it's good news, isn't it? So the NIH has cranked some of these numbers for us. These are some estimates on this slide about how prevalent all of these conditions are, and compares 2002 and 2020. And without going through the numbers in detail, basically in 2020 the estimates, which are fairly accurate, were that there would be 30 million people in the US with cataracts or who've had cataract surgery, about 7 million people with diabetic retinopathy, about 3.5 million with glaucoma, and about 3 million with macular degeneration. That's 45 million of our 330 million people in the US. So this is about 15% of the population have serious eye disease. This is a very, very prevalent problem in our society. Next slide. All right, so actually next slide. This is not just an American problem, and throughout the world, the prevalence of eye disease is increasing. Now, the problems that are causing blindness in the rest of the world are a bit different than in the US. We have the luxury that very few people go blind from cataracts anymore because most people have access to cataract surgery. But if you go to Bhutan or Sudan or parts of the world where there are very few eye surgeons, you will find many, many people who have gone blind from cataract. And some of my colleagues, some of our alumni actually, University of Washington, set up a project called the Himalayan Cataract Project, which you may have seen specialists on or read the book Second Son. And they go out and do these large cataract camps in places like Nepal that have relatively poor access to surgeons, and they may do 300 or 400 surgeries in a day as a team and restore vision to a large segment of a population. One of the things that my colleague Tong Chen is fond of pointing out is that when someone goes blind in the developing world, it is a double whammy to the whole system, because not only do you lose that person's productivity, but someone has to take care of them also. And so you pull the caregiver out of the community and the person who has lost their vision. And so the cost to those communities is even higher than here when someone loses their vision. So that's a whole nother topic in terms of how we might address that in the future, but really this is a global problem. Next slide. And those are just the numbers showing 76 million people, and this slide illustrates a child leading an adult who's lost their vision. Next slide. And one more. There we go. And one more.
Okay.
Go for it again. So what this shows is that by the estimates of the International, for the Center for Healthcare Economics, where they do burden of disease, that is, what diseases are causing the most burden in terms of life years and disability in the world, cataract by itself, that one eye condition, is the number 10 cause for healthcare burden worldwide. So a major, major problem throughout the world. Next slide. All right, so let's dig into the 4 diseases and talk about what they are and what we do for them. So cataract is the most common of these, and as I mentioned, almost everyone who lives long enough will will get cataracts. Sometimes my patients ask me, what actually causes the cataract? And my best hypothesis is that there's something special about the light that comes off birthday candles. Because as long as you keep having birthday cake and candles every year, your incidence of cataract goes up. So that's the only cause I can think of. So if you avoid the birthdays, you'll avoid the cataract. So cataracts are pretty much a fact of life at this point. How do you know you have one? Well, typically the symptoms start out with glare, oncoming headlights when you're driving, and then it becomes difficult to see in dim light conditions. Your contrast goes down, colors seem washed out, and then vision starts to blur. And a severe cataract will actually block the vision entirely, so people really can go blind from their cataracts. We don't see that here very much, but again, overseas, that's somewhat common. When we look in the eye, we can see the cataract. So the lens of the eye, the crystalline lens, is a really unique tissue. It has no blood supply. There's no arteries or veins that go to the lens in the eye. It's one of the few structures in the whole body that does not have a blood supply. And so the cells are very different than the cells anywhere else in the body. They're built to live without much oxygen. And for those of you who are in former lives were biologists or in medicine, the cells of the lens actually undergo this amazing transformation where they lose their nuclei and they just become little bags of protein at extremely high concentration. So if I gave you a bottle of crystalline protein and some water and said, I want you to make a solution of 1.7 milligrams per mil protein, you couldn't do it. As you tried to dissolve the powder in the liquid, it would precipitate, it would crash out. But the eye has figured out how to do this, and that is the concentration of crystalline in the lens. And it's that very high protein concentration that gives it a refractive index that allows it to focus light and do its work. But all that protein in there was meant to last about 40 or 45 years. We really weren't built to live 90 years. And so over time, that high protein concentration does crash out. And when it does, when it precipitates, it essentially forms crystals which light does not go through. It diffracts off of them, and that's what the cataract is. It's literally a rock of protein that forms in the middle of the lens. So next slide. Now this is what the NIH artists, National Institute of Health artists, think a cataract looks like. I think this is probably pretty accurate. It's a general blurring of the vision. It's not focal, it's anywhere you look, you see the same thing. It's blurry, it's glary, things just are not sharp. So next slide. Cataracts come in a lot of different flavors. The type we've talked about is called a nuclear cataract because it happens in the middle of the lens. There's also cortical cataracts, which happen in the outside of the lens. They're very pretty. I have a residency friend, a guy I went to residency with some years ago, who's a very busy cataract surgeon in Syracuse. And every week he sends pictures to all of us of his 3 prettiest cataracts that he takes out. And so his feed to us on his texts all look like this. They're pictures of interesting lenses. But all of them will block the vision, and we treat them all about the same. Next slide. Now, when we talk about how we treat them, we need to do a little history lesson. So in 2007, I think, I was in Paris in a meeting and had an afternoon free and went to the Musée d'Orsay. And they had a temporary exhibit on the earliest daguerreotypes. Photography was invented in France. And the earliest pictures from before 1850 were all taken in Paris by Daguerre and his colleagues. And there was this lovely picture of these 2 sisters that was taken in about 1850. It's a striking picture, and of course it survived her, 157 years at that point. But when I got close to the picture, it really caught my attention. If we go to the next slide, one of the sisters, if you can see this picture, has a bright white pupil on her right eye, and that is a cataract. No question, that is a cataract. So I'm pretty sure this is the first photograph of a cataract. Now, you probably won't see this walking around the streets. In Seattle, very few 20-year-old young people have a cataract that you would see. Because if you had a cataract like this, it would have been taken out to preserve the vision. why did this young lady not have her cataract out? So if we go to the next slide. Oh, these are some other pictures from the art museums in Paris of cataracts. This is a Picasso from, I think, 1904, again showing a woman with a very clear cataract. And the next slide. Monet actually developed cataracts, and if you follow his art, his colors, as you get into the 1910s and early 1920s, wash out completely, and the lily garden turns from green and blue to really brown and orange as his cataracts got worse. And so in 1923, he underwent cataract surgery, which at that time was not a straightforward, easy surgery. That was a 12mm incision across the eye and expressing the lens out. There was nothing to replace it with. Coke bottle glasses afterwards. Some of you remember your parents or grandparents having cataract surgery with the sandbags in the hospital for 2 weeks. So this is Monet recovering from that surgery for 2 weeks. Surgery did not go super well. I mean, the eye survived it, but his vision was not great afterwards. But he did paint the same scene through his cataract-treated eye and his untreated eye, and that's what's shown here. And you can see the amazing difference that it made. His colors came back, and in fact, his colors, you'll notice it's very blue. The natural lens absorbs ultraviolet. The cornea does not. And so in those days when you took the lens out, you didn't replace it. And so he gained the ability to see in the ultraviolet, which most of us don't have. And that's why those colors are so blue. It's, the eye interprets ultraviolet as blue, and it was just inundated by the UV that was out there. Next slide. So the reason why that young lady in 1850 didn't have her cataract out was that at that time it was not the most pleasant experience. Remember, there's no anesthesia in 1850 other than biting on a wood block and a couple slugs of whiskey. There's no ether until really the 1860s, at least in Europe. And the surgery was pretty awful. It was called couching. It was predominantly done. It basically involved taking a metal needle, heating it in a flame, and then poking it into the eye with no anesthetic and pushing the lens out of the way. It wasn't terribly successful. And as you can imagine, the young lady said, you know, my other eye works pretty well. I'm good. Thank you so much. Merci beaucoup. And that was it. So, you know, when do we do surgery now? Obviously, cataract surgery has changed quite a bit over the years, and we'll show an example of that in a second. Really, what I tell my patients is your cataract is ready to come out when you feel it's ready to come out. If the cataract is causing you to have difficulty with the activities you need to or want to do, it's time for surgery. And if it's not, it's usually not time for surgery. And it does drive me a little crazy when some of my colleagues say things to surgical candidates like, you know, you're pretty healthy now, you might not be in 5 years, you know, maybe we should take those cataracts out now. If you hear that, the question mark should be active. Really, the surgery is indicated when it is interfering with your quality of life, and not before then, with rare exceptions. Occasionally, a cataract will be doing something else in the eye, that, like raising your eye pressure or something that requires it to come out, but normally, it's really all about your symptoms. So if we go to the next slide, the surgery, I will show you in a second, but the gist of the surgery in the modern era is we have to get this 13mm rock out of the eye. And we try to do that without having to make a 14mm incision to push the rock through. And over the years, technology has improved so that now what we do is we ultrasound the lens out. So we put a little probe in. An ophthalmologist named Charlie Kellman in New York thought of this technique when he was sitting in his dentist chair, and the dentist was using ultrasound to break plaque off his teeth, and he thought, why don't we use that to break up the lens? And he perfected this technique about 40 years ago now. And this is how almost all cataract surgery in the US is done. We break up the lens, suck it out through a very small incision, usually about 2mm, which is, you know, only the tip of my pen here. That's 2mm is the tip of this pen. So that's the size of the incision that we're working through. and then we replace it with an acrylic or silicone lens that is calculated to replace your natural lens. So most people after cataract surgery don't need a lot of correction for distance. Some people need none, some people need a very weak correction. Most people, though, after cataract surgery have much less refractive error than they had when they went into the surgery. So if we go to the next slide, so this will be our transition point, and let me make a disclaimer here. I'm going to show you a cataract surgery. If you are someone who loves watching surgery, you're going to enjoy this. If you're someone who does not enjoy watching surgery, this would be a good time to take a brief afternoon nap and meditate a little bit. There's not much blood involved in this, but it is surgery, and if you're queasy about watching surgery, you've been warned. Okay, so if we can switch to the video, Katie?
Yes, one moment.
All right.
I'm gonna play.
There we go. So this is the start of the surgery, and we're looking down at the eye. The patients, actually we can turn the audio off, thank you. So we're at the temporal side on the patient's temple of their left eye. The forehead is to the right here, and the nose would be to the left. And the surgery starts with dilating the pupil. The anesthetic is local generally for these, so we use a combination of some local lidocaine and some intracameral, that is a little injection. Now the actual incision there, that's a 2mm incision that's made with a very sharp blade at the edge of the cornea into the eye. And now this is a little cannula that has a viscoelastic, so that's a very thick brown substance. It's actually made out of rooster combs. It's hyaluronic acid, and that's where that comes from. And now a small needle is introduced into the eye, and that's used to take off just the layer of cells that surround the lens called the capsule. That's one cell layer thick that you just saw come off there. So that's about the thinnest incision that you'll see in any kind of surgery. And now a little bit more of the viscoelastic is put in, and now that nucleus, that rock of protein, is in the center, and the surgeon here, I think this is Dr. Shen's video actually, is manipulating the nucleus and making sure that it's free to rotate within the capsule that it's enclosed in. So the next step here is to introduce this device called a phacoemulsifier, and this is the ultrasound. So that little device there is making ultrasound, high-pitched squeals, and those are breaking up the tissue right inside the eye. And this is called sculpting the nucleus. So basically the lens is being removed here with ultrasound. You saw a few little air bubbles there come out of the device. In addition to the ultrasound, it has a little vacuum on it, and as the protein is liquefied, the vacuum sucks the solution back out of the eye and into the there's a little drainage bag on the machine that's running the suction or the aspiration. So this is really just sculpting the lens, and about 3/4 of the lens has been removed at this point. And this is the longest part of the surgery. This is the part that's probably technically the trickiest. So when we train our residents to do this, it takes them about 150 cases to become really proficient at this surgery. So this is pulling the edge of that lens away from the capsule, and that's called the cortex. Again, the whole lens is held in a little bag that's just one cell thick, and the main complication that can occur is if you pull a little too aggressively, or you get a little too aggressive with that phaco tip, you can break a hole in that remaining capsule. That's a very fixable problem, but it does create a little bit of a complication surgically. So you can see how much clearer that is now. The lens is out, and there's just some cortical material that's left. So at this point, the surgeon's going to put in another device. It looks like the surgeon actually talked to the patient. Most people are awake for this, so it's done under some sedation, but not complete anesthesia. So that's the aspiration. And usually we'll say, well, can you see a little bit better now? And the patient will say, well, things are bright, but everything is fuzzy. And that's correct, because there's no lens in the eye. This is the cortex now coming out through that little suction. And you want to get all those little bits of cortical material out. And just leave a perfectly clear little capsule. And that's all that's left here. So at this point, a little bit more of that viscoelastic is going to go in the eye to cushion it right here so that the lens can go in. And the lenses now are folded, so they're folded up like a little taco and put in an injector, and that's the injector going in that same wound now. And then the surgeon is just going to push that lens right into the capsule, there it goes, and then use that second instrument to center up the lens. At this point, the surgery is basically done. So the only thing left to do is to take that viscoelastic out of the eye, and then at the end here, I think the surgeon's going to hydrate the wound a little bit. Usually we don't use sutures anymore. We can just kind of put some water, some salt solution into the wound to swell it up a little bit, and that will seal the eye adequately. So that's just getting all that viscoelastic out and then centering the lens back up again. A lot of surgeons don't use an eye patch anymore. We do, but at the end of this, generally the patient can see. So this is just hydrating that wound. And that surgery is basically done. And I think that was about 4 minutes and 9 seconds, something like that, to remove that cataract. So we've gone from basically, I don't want surgery because it's the most horrific thing I can think of, to, from your perspective as the patient, that was easier than a dental cleaning. Now, it does take our residents 4 years of med school, a year of internship, 3 years of residency to learn how to do this, like you just saw. And so it's not a trivial thing from the physician perspective, but from your perspective, it should be, oh yeah, I got my cataract out in the morning, I had lunch with my friend, and then I went for a nice walk in the afternoon, and that's about as much as it should be impacting your life. So, if we go back to the slides again. Now let's talk about a disease where we're making progress, but we're not quite where we are with cataracts. Again, cataracts really 1% complication rate or less. Most people do very well with cataract surgery. Macular degeneration, so this is really our leading cause of blindness in the US, and this is a retinal disease. So next slide. Again, it's the leading cause of blindness in the US, it's the leading cause in people over age 65, and as I mentioned before, you have about a 1 in 3 chance. And for this audience, if you look to your left, look to your right, 1 of the 3 of you probably has signs of macular degeneration. Next slide. And actually, since you came to my talk, I'm guessing 2 of 3 of you have signs of macular degeneration. How do you know you have it? The main symptom, certainly of the wet form, is distortion. So instead of lines looking straight, they start to look squiggly, and then loss of central vision. And that's the other thing that happens with this. So the next slide. That shows the NIH's little sketch of what they think macular degeneration looks like, and you can see this nice picture of your grandchild and his friend. Suddenly the faces are gone. You can see the periphery, but you can't see the center where it used to be sharp. Next slide. When we look in the eye, what we see in macular degeneration are typically deposits in the retina. And they're a bright yellow deposit that the Germans named Drusen 100 years ago. When we see this, this is pretty much diagnostic of macular degeneration. So when a patient comes into the office, if I look in the back of their eye, I don't need to do any diagnostic testing to give them their diagnosis. I can just look and say, yeah, this is macular degeneration. Next slide. So macular degeneration comes in 2 flavors, and the first flavor that I showed you is the dry form, and that's where we see the drusen. There's also a wet form, and the wet form is where new blood vessels have come up through the damage that the drusen have caused, and they bleed. And when we see that bleeding in the back of the eye, that's what we call exudative or wet AMD. And this is the type. So when I have a patient with AMD, I tell them there's good news and bad news, whichever form they have. For the dry form, the good news is most people don't really go blind from the dry form. It will eat away at the vision, but it doesn't usually leave people completely blind. There are exceptions, but for the most part. But we don't have good treatments for it, as we'll talk about. The wet form, the bad news is it is blinding. So when I was a resident 25 years ago, when someone came in with the wet form, we just said, we're very sorry. There's not much we can do at this point. Today, there are excellent treatments for the wet form. And so those of you who are getting injections of the drugs we'll talk about in a minute, Avastin, Lucentis, Eylea, that's for the wet form. And they're very effective at preserving vision for a long time. but they mean coming into our office every month sometimes for those injections. And let's face it, if you were 20 years old and you thought, how do I want to spend my later years, and you think, I want to pay someone a lot of money to stick a sharp needle in my eye every month, probably not high up on your list, but it works, and it's obviously of high value to the patients who are getting the treatment. So next slide. When we see a patient with macular degeneration, we do some diagnostic tests to get a sense of where the blood vessels are, or if there are any blood vessels. One is fluorescein angiography. This is a test where we start a little IV and inject a little bit of a vegetable dye called fluorescein that fluoresces, and we take pictures of the eye as the dye is going through. It can be very useful in diagnosing this. More commonly now we do a test called an optical coherence tomogram, or an OCT, and that takes a super high resolution picture of the retina and lets us see if there's any fluid leaking out of the blood vessels. Next slide. The dry form, the treatment currently is vitamin therapy. Now, for many things, I'm not a huge proponent of vitamin therapy. There's just not enough data. And when there is data, often it's not what people think. There was a huge clinical trial on chondroitin for osteoarthritis, for example. Many millions of people were taking supplements with chondroitin in it. And the study, when they did a placebo-controlled trial, showed no benefit whatsoever. And that's not uncommon with vitamin therapies. This is the rare exception. So the NIH ran a huge study a few years ago called the Age-Related Eye Disease Study. And they randomized 5,000 subjects to either taking vitamin therapy or not, and looked at their age-related eye disease. Had no effect on cataract, but it actually had a huge effect on the progression of dry macular degeneration. It basically slowed, taking this combination of vitamins A, C, E, zinc, and copper, slowed the conversion of the dry to the wet form down by about 2 years. And that's a lot of time to preserve your vision. So for taking a simple vitamin twice a day, that's a pretty good return on that. And the study is airtight. In fact, it's one of the studies I teach the residents on how to do a good study, because it was beautifully designed and executed. So we do recommend that everyone with the dry form of macular degeneration take that type of vitamin, which goes under AREDS or AREDS 2. There's a couple of brands that sell that. And I should mention I have no commercial interest in anything I'm talking about today, other than seeing you as a patient at some point. Next slide. Now, the wet form, as I mentioned, has a different treatment. And in 2008, Genentech came out with, or got approval for a drug, Lucentis, which is an anti-vascular endothelial growth factor antibody that is really, it's like our penicillin. It's a pretty miraculous drug for the wet form of macular degeneration. And I think, next slide, I think I have the data in here. Yeah. This is from the clinical trial, looking at the vision of patients who got the drug, which are the top 2 lines, and the patients who got the placebo. And this is how many lines they could read on the eye chart. And you can see the 2 groups that got the drug at high or low dose read better for 2 years after they started treatment than the day they walked in. And everyone who got placebo read 3 lines worse on the eye chart. So the split for us was 5 lines of vision. That's the difference between 2100, which is nearly legally blind, and 20/20. Huge difference. So this is, in my career, this is the biggest advance that we've made as a profession, is the ability to treat wet macular degeneration effectively in many patients. So I know from the patient perspective, being told, oh, you have a potentially blinding disease, and we're going to need to do shots in your eye, is not what you wanted to hear. But this is really an effective treatment. People are working on more convenient ways to deliver this time-release drug. There are also protocols that you don't need the shots every month, but maybe every 3 or 4 months after you've gotten established and had loading doses and so forth. So we're trying to make it easier on the patient. But at the end of the day, you still need shots probably for the rest of your life, or at least for many years, to keep this in control. The record, I'm a uveitis specialist, so I treat a little bit of macular degeneration. Mostly I treat inflammatory diseases. But I've seen a patient who came in to see me who had had 140 injections to this point. That's the record that I've seen, but that patient still had 20/30 vision. So, you know, it's not a fun way to treat this, but it really works. Next slide. Glaucoma. Okay, so glaucoma, next slide. This is a disease of the optic nerve. It's the leading cause of blindness in African American and Black populations. The risk factors include family history of glaucoma, diabetes, high blood pressure. Next slide. Like macular degeneration, it comes in different flavors. There is the open angle form, there is the closed angle form, and there is the congenital form. The open angle form is the most common, certainly in the US. In Asia, the angle closure is a little more common, but here it's mostly open angle glaucoma. Next slide. So, glaucoma, people think it's high eye pressure. It's really not. That's one component of it. There's really three components to the disease. You have to have high eye pressure that's causing damage to the optic nerve that is causing vision loss. And that triad of high pressure, optic nerve damage, and vision loss, that is glaucoma. Next slide. So we see it when we look in the eye as the optic nerve being cut or degenerated. This is a picture of what the NIH artists think glaucoma looks like. You'll notice it's the exact opposite to macular degeneration. Macular degeneration takes the center of your vision out and leaves your periphery alone. Glaucoma takes your periphery out and leaves the center alone until late in the disease. You don't want to have both diseases because then you lose your center and your periphery. And because they're very common, unfortunately, there's a lot of people who have both macular degeneration and glaucoma, and that's a bad combination. Next slide. So, the vision field loss that we see in the disease starts way out in the periphery and then moves in. And typically it's worse either above or below the horizon. So it's not uncommon for people with advanced glaucoma to lose the upper part of their visual field or the lower part. Next slide. The challenge with glaucoma is that it is asymptomatic until the late stages of the disease. People don't know they have this unless they get checked regularly. And it is just tragic when someone walks in with vision loss and we look in their eyes and go, oh my gosh, you've had glaucoma for 20 years, haven't seen an ophthalmologist, this could have been prevented, and it's too late by the time they come in. We can't reverse the damage in glaucoma, we can only slow it down. The one exception to this is a kind of glaucoma called angle closure. Some of you may have had a laser treatment to your pupil, to your iris to prevent this. This is something that happens in people with what we call narrow angles. And it typically is a very sudden onset of very high pressure, usually when you're awakening or after you come out of the theater or somewhere where your pupils were dilated. And it sends people to the emergency room almost immediately because your pressure can go up to 70 and people get sick to their stomach and nauseated. And, we can fix that, but again, it's better to prevent it than to fix it. Next. The signs of glaucoma are generally elevated pressure and cupping of the optic nerve. So the pressure normally is under 23 millimeters, and we usually use that little blue light, although the tonal pens work very well also to check pressure. That's why you have your pressure checked every time you come to the ophthalmologist or optometrist. We're screening for that risk factor. Next slide. So the screening recommendations from the American Academy of Ophthalmology are that everyone over 40 have a dilated eye exam every 2 years, no matter who you are. But if you have any risk factors, that is a family history of glaucoma or macular degeneration, if you're African American, if you're diabetic, you get an annual dilated eye exam. Some practitioners now are using wide field cameras so they don't have to dilate you, non-mydriatic cameras. In my opinion, not quite ready for prime time. I don't think it's a substitute for a good dilated eye exam. Also, there's some business, monkey business around that where particularly optometrists may charge you for the privilege of not being dilated and do the camera test. And it seems to me that charging someone out of pocket for a test that's inferior to the one that we do for free doesn't seem like good business sense, so I'm not a big fan of that. And if you are offered that by your eye doctor, again, the little question mark should go up. Next slide. Treatment for glaucoma, well, the goal here, the only modifiable risk factor, you can't change who your grandparents were. So the modifiable risk factor is the eye pressure, and we usually start by bringing that down with Eye drops, there's many different kinds of eye drops that lower the eye pressure, and lots of people are on several of these to lower their pressure. We can also do laser therapy, laser treatments that are very effective, about as effective as eye drops, and if your ophthalmologist says, hey, I want to do a laser to lower your pressure, that's a good option. That can save you a lot of hassle with the eye drops, and it's a very safe procedure. Now, if those fail, then we have to do full surgery. Next slide. And I'll spare you the videos of these surgeries because they're a little gorier than the cataract surgery, a little more blood. But basically, this is a very ancient surgical technique. It's essentially a trephining. So we make a hole in the eye by some means with a special device, and we let fluid flow from outside the eye to underneath the conjunctiva. And so it's a shunt. In neurosurgery, it would be a VP shunt, and for us, it's a glaucoma shunt. Sometimes we use a tube to connect them. Sometimes we can just make a channel surgically. The tube is called the glaucoma drainage device, and the direct connection is called a trabeculectomy. And these are very effective, but they're big surgery, so we try to avoid these. They do have some complications that can happen, and generally they're sort of our second-line treatment for this condition. Next slide. And that's a picture of the shunt that we put in. It looks like a tiny soda straw. Again, very effective, but you end up with a piece of hardware. That little shunt is in your eye for the rest of your life. Next slide. So our last disease we're going to talk about is diabetic retinopathy, and this is, again, a very common disease, a disease of the retina. Next slide. It is the leading cause of blindness in working age people. If you have diabetes, there's a high chance you're going to get this. 7 years after type 1 juvenile onset diabetics get their diagnosis, 50% of patients will have diabetic retinopathy. By 20 years of diabetes, it's about 90%. So if you have diabetes long enough, you're likely to get some diabetic retinopathy. And we recommend that type 1 diabetics get screened as soon, within the first year of diagnosis. For type 2 adult onset, we don't really know for many people when they got their diabetes, so they may have had it for years before it's diagnosed. So we usually recommend if you're type 2, you get screened immediately and then annually thereafter. Next slide. This just, again, to highlight the point that diabetes is epidemic. The number of diabetic Americans has tripled over the last 3 decades. And with that, we have a small epidemic now of diabetic retinopathy as well, with 1 million new diagnoses of diabetes a year. That's a lot of diabetic retinopathy. Next slide. Who gets this? We don't really understand why some people get it and some don't. We know that the length of disease matters. We know that blood sugar control matters. If you have tight control, you're less likely to get diabetic retinopathy. If you have poor control, you're more likely to. And then there's some genetic factor that we don't understand yet, but some people are protected from ever getting this. And some people are very sensitive, and a year after they have their diabetes diagnosis, they have florid diabetic retinopathy. Next slide. Symptoms, here it's a lot of different ones. You can have blurred vision or floaters, sudden loss of vision, you can get pain if the blood vessels grow in your iris. Lots of different presenting symptoms. Next slide. And this is what the artist rendition is, and this one is kind of, you can pick almost anything that might happen in the eye and it can be attributed to diabetes, but one is that you start to lose bits and pieces of things. Next slide. So this is what the normal retina looks like. I showed you a picture like this before, and next slide, this is what the diabetic retina looks like, and it develops little hemorrhages, exudates come out of it. Again, there are several flavors, like all of our disease. This is the, what we call non-proliferative phase of diabetic retinopathy. This is where we have little bits of hemorrhage and little bits of exudate. Next slide. This is the proliferative form, which is more serious, and this is where new blood vessels grow out of the retina, and they're not too smart. They grow into places they're not supposed to be, like the jelly of your eye. They bleed, and when they bleed, you lose vision suddenly. So this is a disease where you could wake up and go, oh my gosh, I can't see out of my right eye today. Come in and we'll say your eye is full of blood from diabetic retinopathy, and we either let it clear over a few weeks, or we go in and surgically remove it depending on the circumstances. Next slide. So the treatment for both the non-proliferative and the proliferative is generally around making the bleeding go away and the new blood vessels go away. And we have two mainstays of disease. One is the drugs that we just talked about, so those same drugs, Lucentis, Eylea, Avastin, are all very good at making the blood vessels go away in non-proliferative and proliferative diabetic retinopathy, so diabetic patients also often get those treatments. The other thing we do for this disease is we laser the retina. And this is a very effective treatment, particularly for the proliferative form, but it's a lot of laser. So we usually do 2,000 or 3,000 little burns in the retina and ablate all of the retina that's ischemic. It's sort of cutting off 2 fingers to save the other 3 kind of philosophy with frostbite. We ablate the outer retina, that's the very far part of the visual field, and that's very effective at making the blood vessels go away, but it's at the cost of your night vision, which will be worse afterwards, and some of your peripheral vision. Next slide. And that's a picture of what the laser photocoagulation looks like in the retina after we've done it. The lower part was done a couple weeks prior, and the upper part was done more recently, and you can see all those little hundreds of little burns there that are put in with the laser. Next slide. So that is a quick run-through of the 4 major reasons why people lose vision. Just a quick plug for who we are. So we're your neighbors, right? If you walk by the other 2 hospitals between us, we're at Harborview is our main office. We also have an office at South Lake Union at Dexter and Mercer. At the South Lake Union campus. We are the ophthalmology department of the University of Washington and of the medical school and for UW Medicine. Next slide. So what is an eye institute? An eye institute is a place where we consolidate all of the things that we do, which means taking care of patients, doing surgery, training new doctors, and that's uniquely our obligation in this region. And doing research. And if you go around the country, there's many eye institutes. Those of you who split your time might go to Bascom Palmer Eye Institute in Miami or Mass Eye here in Boston. We are the region's eye institute here, just 6 blocks down the road. Next slide. And again, we're really a central location for everything. Whatever your disease is, we can see you in one location. We are very much a part of this community. That's why I'm here today, is to help educate and be a resource. We're happy to see people. We have a great ophthalmology community in Seattle. We trained a lot of the ophthalmologists in Seattle, so we know, like, and trust them. Those of you who have community ophthalmologists, wonderful. We're doing our job. If we can be of service to you, we're happy to do that too. And so we're happy to see people for care, opinions, whatever. That's a big chunk of what we do. We also have a very strong research mission. We are the #2 recipient of NIH dollars among departments of ophthalmology in the country. So we have a very strong research division, and what we're trying to do, and if you would like me to come back and give a second talk, I'd be delighted to talk about some of our research, is that we're trying to use the great science that flourishes at the University of Washington and direct it towards curing some of these eye diseases that we've talked about. So if you're interested in learning more about that, Katie Bunton is here, who's our Director of Advancement. She has some materials to share. We have a newsletter that if you want to sign up, we're happy to have you on our newsletter. And we're always looking for ways to engage with our community. And in fact, if you're really passionate about this, we have a community board that we invite in to help advise us on how we can better interface with our community and serve our community. Next slide. So with that, and we can skip this next slide, and next one. And I do want to mention the Retina Center. For those of you specifically with retinal disease, we have a dedicated Retina Center that was made possible by a large gift from Angie Corrales-Johnson. Some of you who have been in Seattle a long time will remember her late husband, Roger Johnson, who may have been your ophthalmologist. He took care of a lot of people over the years. And we do provide retina services, both research and clinical, at that beautiful setting in South Lake Union. And next slide. And next slide. So, to conclude, we've talked about 4 of the leading causes of blindness: cataract, diabetic retinopathy, macular degeneration, and glaucoma. We've talked about the treatments that we have for all of them and the things that work and don't work so well. And we talked a little bit about research, but again, if we want to talk more research, I'm happy to come back and do that at a second visit. So I thank all of you for your attention. I'd be delighted to take questions from the audience. And again, thank you for the opportunity to come and speak to you today. here. Yeah, we'll start here. My right, I'm sorry, my right. I should know that because I constantly tell patients to look to their right and they're looking to my left. So,
is there any benefit?
Yes.
Is there any benefit to taking AREDS before you have a diagnosis?
yeah, I'm going to repeat the questions for the video also. So, the question is there any benefit to taking AREDS before you have a macular degeneration diagnosis? We don't know. They did look at a population in the study that did not have macular degeneration, but the study was not adequately powered with enough people to answer that question. So the study did not come up with a conclusion, and that's because the annual rate of people developing macular degeneration is relatively low, and you'd have to study 20,000 people for 5 years to see whether there was an effect or not. I don't think it hurts. They did do a very good study on the side effects of the vitamins, and they were really minimal. They looked at hospitalization, Alzheimer's rates, cardiac events, all sorts of secondary outcomes, which were not elevated in people taking vitamins. So I think it's safe to say the vitamins are safe. I don't think there's a downside, because I think there's a fair chance that it would stave off disease. But I can't tell you that definitively. The study just wasn't powered to answer that. Yes, in the front. Sure. If you'd like, we can also just have people ask their questions and I can repeat them.
Is there any benefit to taking the AREDS once you've been diagnosed?
Yeah, so yes, generally yes. Now, if you're at the wet form, so the question is there benefit to taking AREDS after you carry the diagnosis? Definitely if you're in the dry form and you have moderate to severe disease, that was the group that they showed the biggest effect in. So definitely if you have dry form. If you already have wet form, they didn't really look at further progression on the wet form, but generally people don't have the wet form in both eyes at the same time. And so usually one will be wet and the other one is still dry. And so in that case, obviously it's still worth taking the vitamins. So I would say generally yes. If you carry the diagnosis, it's worth taking the vitamins. Yes, down in front on the left, my left.
Is there an average amount of years that you have the dry before it turns to the wet?
So the question is there an average amount of time that you have the dry where it turns to wet? First, only about a third of the dry ever turns to wet. So most people who have dry form never develop the wet form, which is good news. Second, it's not really an average time. It increases basically linearly with the duration. So the longer you have the dry, the higher the chances that it's going to turn to wet. We draw curves of that, and there's not really an average time with that. But with the accumulation, the age at which most people are diagnosed, and life expectancy, generally this is a disease that people develop in their 70s or 80s. The expected life expectancy for someone who's 80 is into their early 90s. About a third will develop the wet form within that time period. And that's about, I think, the best answer I can give to that.
I was told I have low vision, and at that point, I was at the University of Washington the whole time, the eye clinic there. But after they said I had low vision, they just kind of dismissed me, and that was the end of it.
Yeah, so the question is, when you're diagnosed with low vision, what do we do? So for many years, we had an excellent community service here called Sight Connections in Seattle that provided low vision services. Low vision is a specialized branch of optometry, primarily. Most of the providers who do low vision are optometrists. So I think most of this audience probably knows this, optometrists are not medical doctors. They don't do surgery. They go to optometry school for 4 years and practice, as opposed to an ophthalmologist who's gone to medical school for 4 years and then does 4 years of residency to become an eye surgeon. Most low vision is done by optometrists, and there was a very good group at Sight Connections. Unfortunately, you probably remember reading about this a few years ago in the paper, they got into financial trouble, and they had hitched their wagon to Value Village, who was their major supporter, and then when Value Village collapsed, they lost their funding source, and they went out of business as a not-for-profit, which was just awful. This was in 2019. Thankfully, the Lighthouse for the Blind down in Soto has developed an excellent low vision program. So if you're looking for low vision support, we don't provide that at University of Washington. We don't have much of an optometric service, unfortunately. I wish we could, but it's a resource issue. We just don't have the resources to provide the low vision support. We refer our patients now to the Lighthouse, and they do a very, very good job of both low vision aids, reading aids, magnifiers, and also vocational rehabilitation for people who still want to work.
Could I just call the
Absolutely. You
and
can
make an appointment?
call the Lighthouse, and they
talk to them immediately, straight away.
And talk to them straight away. They provide those services. Unfortunately, we do not. You're correct.
Okay, thank you.
Yeah, on my left.
Just to continue, son? Yes. The product that Bausch & Lomb is putting out called Preservision, is that what you're talking about?
Yes, it is. So it's got to be there's three, to my knowledge, 3 companies that make the vitamins, or 2 companies and 3 different vitamins. When the study was done, the one error, as I mentioned, it was a great study, but they made the error, I think, and this was an NIH publicly funded study, of using a vitamin combination that Bausch & Lomb had already patented as a combination. And that was a political error, because basically then the benefit of the study benefited Bausch & Lomb specifically. If they had used a slightly different combination of vitamins, I suspect it would have worked as well, but they didn't. And so Bausch & Lomb holds the patent, or held the patent, it's expired now, on AREDS vitamins, AREDS vitamins. That was beta-carotene, zinc, copper, vitamin A, vitamin C, and vitamin E. The vitamin A was beta-carotene. Now, if you're a smoker or a previous smoker, you should not take beta-carotene. It actually increases cancer risk, lung cancer risk. So a whole second study was done substituting another vitamin A derivative called lutein, lutein and zeaxanthin for beta-carotene. And those are called the AREDS 2 vitamins. And Bausch & Lomb also makes those, but I believe there are some other companies that are licensed, including Alcon, to make AREDS 2. So from the consumer perspective, you want to see the letters AREDS on the vitamins, preferably AREDS 2. Doesn't matter what brand it is, as long as it's using that same combination that was tested in the clinical trial.
Thank you. I don't know whether to leave it on the shelf or dump it.
You know,
It's not pleasant. I mean, you're supposed to take it with food.
Yes.
But the zinc kind of gets you.
It's not the easiest thing, and I wouldn't recommend it if the data weren't so strong for benefit. No one knows which components. When they did the clinical trial, they took the minerals and the vitamins and separated them, and it turned out neither was sufficient. But whether it was the zinc or the copper, or whether it was the vitamin A, C, or E, we don't know at this point. So if you really can't tolerate the zinc, you might replicate it by taking vitamin A, C, E, and copper and see if that, I mean, it wouldn't hurt, and it might have the benefit if you really can't take the zinc. Yeah, on the left. I'm watching both sides here.
Can you hear me?
Mm-hmm.
But this is possibly the meanest question. What about the insurance coverage?
For what?
Well, for any of the surgeries, or
Yeah.
I know, well, many of us have gone through them all. Can I get this? Is it covered? And so on.
Yeah, let's see, what time is it and how long do we have to talk
That will
about
take
this?
all day, does it?
So there are 5 stakeholders in modern medicine. There's you, the patient. There is me, the physician. There is the hospital and the medical system. There are the pharmaceutical and device companies, and there are the insurance companies. The purpose of the insurance companies and the medical device and the pharmaceutical companies is largely to get between you, the patient, and me, the doctor, so that we can't do what we want to do together. We are in an extremely broken system, in my opinion, extremely broken, because there's essentially no normal economic brakes on certain parts of what we do. One of those breaks is around drugs and devices, where basically, and again, this is opinion, this is not the University of Washington's position on this, I want to be clear, it's my personal opinion. The market forces that normally would limit costs are not allowed to propagate because the political system has provided protections for example, drug manufacturers that allow them to price whatever the market will bear for a drug without any grounding in value or actual manufacturing costs. There's really no competitive market for a drug for 20 years. And that's why a drug like Humira, which some of you might take, by itself grosses AbbVie, the company that sells it, $22 billion a year, one drug. If Humira were a country, it would rank 103rd in GDP among the 180 countries that list the GDP. It's larger than about 70 countries in terms of its total economic value. One drug. So the insurance companies then also have an issue in that they are providing insurance for something that's going to happen, right? No one gets out of here alive. At some point, everyone needs medical care. And so the idea that you're buying insurance against something that might not happen, like your car insurance, just doesn't hold here. You're going to need this service, right? These are all for-profit entities or pseudo-for-profit entities for the most part, and most insurance companies make a healthy 20% profit. Drug companies, the drug companies' aggregate profit as a sector of the economy is second only to tech. In terms of how much profit they make, and in fact 11 of the top 50 companies in the world are drug companies. Have you ever heard of a drug company going out of business? No. An insurance company going out of business? No. They make an enormous amount of money. And their job is to fight each other with you and me as you know, the collateral in the middle to say, that's a really expensive drug. We're the insurance company, we're not going to pay for that. And the drug company says, well, we developed that drug, we're entitled to our profits on that drug, and the patient needs that drug. You better pay for it. And you're saying, well, I can't get my drug. And I had this experience at Rite Aid this week. I went, my doctor put me on a different medicine that wasn't on my plan. And I went in and said, can I get my prescription? They said, oh, we're still trying to get a prior authorization. And I understand that because I spent a lot of my time on the phone trying to get prior authorization. And I said, well, how much would it be if I paid for it out of pocket? And which is exactly what the insurance company wants me to do, which is, but you know what? It's worth it. I don't want the hassle. And they said, oh, it would be $1,000 for the month. And I said, okay, you know what? I'll wait for the prior authorization. They said, wait, let's check one thing. And they said, oh, there's a good RX coupon. We can sell it to you for $50. And I realized I'm being had worse than at the used car dealership. This beautiful car is $1,000, but for you today, $50, I'll give it to you. But I really didn't want to wait another 3 weeks for my medicine and take my doctor's time, which I value, for him to go fight for a pre-authorization for a $50 drug, right? So anyway, I think the system is horribly, horribly broken, and it's not a mean question at all. It's a very legitimate question. We, the patients and the doctors, have been carved out of the political process on this. We really have no say in what's happening in our own healthcare, unfortunately, and it's really being dominated by the three major, the hospitals, the pharma companies, and the insurance companies, who have the political power to craft things in ways that work for them. That's a very dark answer, my personal opinion.
And they're those lobbyists.
It's all about the lobbyists. You know, it's unfortunately the way our political system works is that that's where if you donate, you get access, and you know, that's what drives the system, and we don't form a collective as patients. Doctors are busy taking care of patients. We are a terrible political organization. But the other ones are very effective, and they get what they want, and this unfortunately leaves us in the lurch. Yes?
I don't know why this is not. I have glaucoma, and as long as your numbers are low, is there anything else besides eye drops?
Yeah, so the question is, when you have glaucoma, and you've controlled your pressure and your numbers are low, is there anything else that you can do at that point? And unfortunately the answer right now is, other than not further poisoning your nerve by smoking or drinking excessively, at this point we don't have anything else to offer, which is very sad because a lot of people have lost a lot of vision. There's some excellent work on stem cell replacements that's happening at University of Washington, and again, if I come back, I'll be happy to talk about that, to try to regrow the nerve and replace the cells that have died, but we're not ready for human trials yet on that. That's in primates, which is getting quite far along, but we're not quite in humans yet. So we're working very hard on that to try to reverse glaucoma. At this point, we can't.
What if we have macular degeneration?
If you also have macular degeneration, as I mentioned, that's a really bad combination to have, but at least the macular degeneration can usually be treated independent of the glaucoma. So if the pressure is low and you're getting treated for macular degeneration, that's about the best we can do right now. It means a lot of trips to the ophthalmologist. Yeah, the AREDS vitamin, again, if you have macular degeneration, that's worth taking. It does not seem to help for glaucoma, though. Yeah. Yes?
I've been getting the injections for macular degeneration for about 12 years. And after every injection, I get terrible discomfort in my eyes. Sometimes it'll last 2 weeks, but usually at least 3 or 4 days. And I know no one else that gets that reaction.
Yeah, so the question is, after the injections for macular degeneration, having discomfort for a couple of weeks. Oh, mic off. We run out of battery. The switch is on. I'm not sure. Is the audio still?
It's still on.
Is it still on? I don't think it's on. It's off.
I don't pass, because it's dead battery.
Yeah. So I'll repeat the questions. So the question is, after getting injections for macular degeneration, pain or discomfort that extends for weeks afterwards. That's very unusual. One possibility is if you have an allergy to the betadine that's used to prepare the surface. Occasionally people will have a bad reaction to the iodine in the betadine. There are alternatives, like cyclohexidine. You might talk to your ophthalmologist about prepping the eye with a different prep and see if that helps. Because sometimes people get corneal problems from the betadine that causes a lot of discomfort. Yep, in the back.
Is UW working on inflammatory diseases like thyroid eye disease that has all this hype on the TV now?
Yeah, so the question is, are we working on thyroid eye disease? We take care of a lot of thyroid eye disease. Thyroid eye disease is something that happens to people with certain forms of hyperthyroidism. Typically, you remember Marty Feldman with his sort of bug eyes? That was classic dysthyroid ophthalmopathy. There is a new drug, tezepelumab. They always give it a name that's very difficult to say, which is a monoclonal antibody against an insulin growth factor receptor that is a miracle drug for thyroid eye disease. So people who have very bad thyroid eye disease, where we used to have to use radiation like in cancer treatment, Now this infusion is pretty remarkable. The downside is it costs $250,000 for a treatment course. So it's another one of these drugs that's priced at what the market will bear. I could make it in my lab for $100, but I'd get arrested for selling if I did that. But yes, there is a lot of progress in thyroid eye disease at this point. We don't have a specific research program on it. There's only a few places in the country working on this type of stuff. Michigan is the place where they developed that particular drug.
So,
Yeah.
can I ask another question? So I was sucked into that whole thing because my symptoms look similar. Oh, thank you. My symptoms look similar with 2D MAC surgeries, having some difficulties in the right eye and having triple vision. But now that I'm really working with scleral lens, I'm really excited because what look like symptoms of another disease can be treated differently.
Yeah, excellent point. So it sounds like you've had a couple of cornea transplants in both eyes, and that's another area that's advanced dramatically over the past few years where we don't have to transplant the whole cornea anymore. We can do parts of it, like the inner part DMAC or DSEC. But there's still some optical problems sometimes with those surgeries, and scleral lenses, which are big contact lenses that cover the whole eye, are kind of miraculous for surface disease because they correct whatever the problem is in the front. You basically replace it with a big bubble of fluid and a hard lens. And many people whose vision can't really be corrected otherwise do really well with scleral lenses. The downside is most insurance companies don't pay for them, so they can be very expensive. They're very hard to fit. You need a really good optometrist to do that. Our Lions clubs here in Seattle, under Fred Menifee, actually have a program called Gift of Sight where we, the Lions provide the funds to help people who need scleral lenses get them. And we do have a program for fitting those at the Eye Institute. So we do scleral lenses, often for burn victims or people like that for whom they're really wonderful treatments.
Question here.
Yep.
Years ago, when I was diagnosed with the onset of macular degeneration and cataracts, my doctor recommended that I take lutein or Preservision or any one of those. Is that the same thing?
Same thing. Preservision are the AREDS vitamins, and the ones, AREDS 2 are the lutein vitamins. So that was the same thing that the doctor was recommending.
Okay, thank you.
So Katie Bunton, who's in the back, does have some materials if anyone would like. We have some information sheets, and she's happy to sign people up for the newsletter. I'm going to stick around and happy to do one-on-one questions if people have additional questions, but I also don't want to keep you from your dinner, and so I thank all of you again for your attention. And,